Hi everyone. My name is Sajan. I'm a pediatric hematology registrar, and I'm currently doing a PhD project. So I'm at GS Institute of Child Health and at Great Ormond Street Hospital. And I've been invited today to tell you a bit more about pediatric acute leukemias, and I've been told that you're mostly ST4 and ST5 pediatric registrars, so I've kind of tried to tailor today's teaching on the topic as something you might need, and particularly in a DGH type of setting. So most of the things I did not go, and I will not go too much into detail about treatment and diagnostics and finally, but I'm quite happy to take any answers at the end or during the session. So let's begin. So first we will have a case, first case, which is that all pretty much real cases, and maybe change the age. So we had a 12-year-old male who presented to a DGH pediatric A&E, and he presented because he had a 7-day history of tiredness and increasing headaches. He also had 2-day history of fevers, around 5-day history that he started feeling some lymph nodes, and he wasn't even sure, but when this started, but he did have some petechiae on his abdomen. On examination, you will obviously took good history. There was no previous medical history, nothing relevant in the family history, but on examination, he appeared alert, he appeared very tired. There's good air entry bilaterally, but you have found a splenomegaly of 8 to 9 centimeters below coastal margin, and there was no O2 requirement, and gross neurology appeared to be normal. So if a patient like that presented to you in an A&E or whichever pediatric assessment unit type of setting, I just want to see what laboratory investigations would you do as your first line investigations in a DGH setting. So anyone, if you can join in. No, so obviously I suspect that anyone joining in, no? So obviously,
people often use the chat function rather than the microphones sometimes.
Okay, perfect. Can we see something? So yes, full blood count, film, CRP, all good suggestions. The ESR, film, both all fine suggestions. EBV, serology, yes, it would be helpful somewhere down the line. So you're quite right. We need to look at the basics, and your basics always are your full blood count. So full blood counts come back quite quickly, and it revealed that your patient is anemic with a hemoglobin of 78, has quite high white cell count of 423, platelets are 18, reticulocyte count, absolute count is 18, which is on the lower side. Most trusts have 25 as your lower end of normal. There's no differential provided, and blood film is still pending. Obviously, with a new presentation that you're suspecting of any malignancy or anything, you should check your all your standard blood, so your U's and E's, and we'll come back to why we're checking all of these. Your LFTs, clotting was also normal. CRP was very mildly raised at 14, and your hematology registrar came in for this blood film. And the blood film showed obviously blast. I'm not sure how much you can see there. I would like to point, I will put, let me just So with blood films, obviously you won't be involved too much with blood films, but I would like to point out how to interpret sometimes blood films. If you're a hematology registrar who might not be as experienced in calling blasts, or if it's not such a obvious picture, so with white cell count of 423, it's fairly easy to see blasts, and in this film, if you can see, it's all blasts in your visual fields. But I would like you to pick up how we somehow describe blasts. So blasts are obviously mostly pathological cells, or should I say always pathological cells when they're found in peripheral blood, and we sometimes might describe instead of calling them blasts if somebody's not so certain that they are blasts. So the description normally is that it has a high nuclear to cytoplasmic ratio. So that means that let me just move this out of the way. So you can see this cell, which is your typical blast. The nucleus is huge and it takes up most of the space, and there's very little scanty cytoplasm. So that's your high nuclear to cytoplasmic ratio. And then you will see that inside the nucleus, and I'm not sure whether your picture quality is good enough, but you can see small bubbles, which we call nucleoli, and that's why your DNA is transcriptionally active, because blasts are quite transcription active cells. So I'm putting this out just because sometimes you might see this in the description, and it might not always be a clear-cut blast scene, and this was certainly the case with this young man. I mean, everything was covered with blast, and all of these cells except the one in the middle, which is kind of this plastic neutrophil, but they're all blasts, and we did report them as that the whole film is faced with blasts, and this is a confident diagnosis of acute leukemia. Okay, I've spoiled it, but you do know what the topic is today. Is there any other investigations apart from these baselines that you would do? As additional, I can see somebody has put already EBV serology. Is there anything else? Any other tests now they have that you're suspecting leukemia? What else would you like to know? Chest X-ray, excellent. Every suspected leukemia or malignancy should have a chest X-ray. Well done. Bone marrow biopsy, yes, of course. That will be your investigations once that transferred to your principal treatment center, so your tertiary center, and that will be diagnostic. Normally, we don't do abdominal ultrasound routinely, just because, I mean, for most of the time, and unless you're suspecting some other pathology, and when you have clear indications, we don't normally do abdominal ultrasound. Definitely, you would not have to do it in the DGH setting before you transfer a patient. So your chest X-ray was definitely a good shout, and this is mostly important because immunophenotype and urate level, well done, all quite important. Urate level at your DGH level before you transfer a patient is more important than immunophenotype, but we'll come to that. So chest X-ray, absolutely one of the most important things. Why? Because some leukemias, mostly TLL or T-cell malignancies in general, do tend to present with more lymphadenopathy, or sometimes with mediastinal masses, which can be impeding on the airway. And obviously that's an emergency that needs to be picked up early, and there's a special set of rules how to manage children with mediastinal masses. From your biochemistry, as you very well pointed out, urate is quite important, and that's one of your tumor lysis markers, how quickly the cells are lysing. Calcium bone profile, LDH is quite helpful with hematological malignancies. It's fairly non-specific, so it won't tell you much if it's normal, but it does help us. It does help us sometimes. What I would urge for you to think, especially when you're in a DGH setting, is G6PD screen. Not infrequently do you have to transfuse a child locally, and most of the testing that we need as a baseline investigation before starting treatment, we can do from white cells, we can do genotyping, and including G6PD, but G6PD genotyping takes such a long time, and you might need G6PD results a lot earlier, so we need to do them from red cells. So if you can think of doing G6PD screen before transfusing, or just as part of your routine screen, that's a really good that would be good, really good practice. Obviously, sending group and say whenever you know somebody's anemic. Clotting, I will mention clotting several times throughout this teaching session, and that's only because I've noticed when we get a referral, oftentimes clotting has not been done, and I think that's in part due to not understanding what processes might influence clotting and why it's so important. And we'll come to that. And obviously, if the lab film was not reported, get in touch with your local hematology team. Every hematology registrar and consultant can tell blasts and can tell fragments, which are your two most important things. Obviously, fragments have nothing to do with leukemia, so everyone should be able to tell blasts. I can see Asma asks why G6PD. So G6PD is important because when you start treatment, especially children with high white cell count or anyone with evidence of tumor lysis, we use a drug called respirocase, which is a very potent hemolysis activator and in children who are G6PD deficient. So it has happened, unfortunately, not in children patients, as far as I know, but in some adult patients, the G6PD, that respirocase was given without G6PD being given, and they completely hemolyzed down to 20s. So we always need to have a G6PD screen done before giving respirocase. And as I said, if you transfuse them or if they get blood, you can't establish a G6PD level or G6PD screen. So it's important that it's done before the transfusion. And that's why I think it's a fairly cheap test. It's done in all the centers, in all the hospitals. So if you can do it as part of your secondary bloods, after you have a working diagnosis of leukemia, that would be really helpful, because sometimes we can't do it if the child has already been transfused. So that's the reasons for G6PD. Why is it important that the local hematology team see the film? With white cell counts of 400, there's not many causes that can cause that, but it is vastly helpful for us, especially when you have counts in the 50s, 60s, where it still very well could be infection and neutrophilia in just a left shift. Obviously, you might not have that pronounced thrombocytopenia and anemia, but it is essential that the local team also have a look at the blood film, and that helps us help you with our referral and determine how urgent the transfer is. Then chest X-ray we've established, and this young man luckily had a normal chest X-ray. Further imaging you've asked about, and we talked about abdominal ultrasound. I've not routinely seen it being done in DGHs, and not even when they were transferred over to us. Sometimes, obviously, if you have worries about any acute intracranial pathology, you might think about head imaging, obviously if neurology is present, but most of the times your chest X-ray is the only imaging they will need before you transfer them to a tertiary center. And obviously we would already touch what your working diagnosis is, and your topic is acute leukemia. Does anyone know what your next steps in a DGH setting? So now you have a working diagnosis of the leukemia, what would you do next? Yeah, call for help as always. That's number one. Who would you call for help? Contact Gosh, that's right. You would contact Gosh. Anything else you would do locally? Leukostasis, yes, you would absolutely be worried about leukostasis and this child's dehydration, absolutely, and this is what we're coming at. So we need to start fluids, which rate, so treat anemia. Anemia is 78, I believe, so I probably, well, depends if the child is symptomatic, but especially during COVID time, our transfusion threshold is below 70. It used to be below 80, but I would always discuss, well, I would like anemia to be discussed with us and transfusions discussed with us. Low platelets. Platelets are 18, and the child is paraxial, so yes, platelets would be reasonable. So obviously we need to start IV fluids because this child, as you hyperhydration can worsen anemia. Leukostasis can see HB. Yes, HB can drop further, but I wouldn't be too worried about that. But we during the teaching we'll discuss about how to support. Yes, IV antibiotics are reasonable as well. How to support people, how to support patients. So IV fluids, we will discuss which rates. I also am a great fan of starting allopurinol early. Why? Because some blasts can lie spontaneously, and it's good to give extra protection for tumor lysis from just with allopurinol. Obviously refer to your PTC, transfuse if needed, you've said that, and start antibiotics if paraxial. What I think everyone should always think, and mostly you are quite good with that, is that you need to discuss your working diagnosis with the family. They should not be informed of it just by walking onto a cancer ward, and unfortunately there has been sometimes not enough communication, and parents do get quite shocked when they go onto the ward. Or I mean, everyone would, of course, but just be aware that you do need to tell them what you're suspecting, or in this case, when you have this obvious picture, it's not wrong to say it's leukemia, we don't know which one, and we are transferring you somewhere where we can provide care. And this is what happened with this 12-year-old. So talking broadly about leukemias in children, obviously leukemias are malignant processes, is a malignant process characterized by proliferation of hematopoietic stem cells. There is a general division into acute and chronic leukemias, and it does not designate the duration of the leukemia. It designates just the level of maturity of the cells, pathological cells that happen. Children are most often affected by acute leukemias. CML can sometimes occur in children as well, but that's rare stuff. So I'm mostly going to talk about two most common leukemias in children, which is acute lymphoblastic leukemia, or ALL, and acute myeloid leukemia, or AML. One subtype of AML is called APML, and it is very rare, but it is very important to recognize it early because it can cause DIC and significant coagulopathy, and significant morbidity, mortality can happen in the first 30 days of presentation and induction because of this coagulopathy. So we'll have a special segment just on that. It's also important to note that ALL is the most common malignancy in childhood, so there will be more talk about ALL. So can you give me some ideas what are the clinical symptoms that you might see in a child with an acute leukemia? Just a few things to get the thing started. Limping, yeah, well done. Bruises, absolutely, most present with that. Lethargy, pallor, all good shots. Weight loss, yes, absolutely. Lymphadenopathy, bone pain, yep, all very reasonable. So first is a fever, quite common one. And this is a list which is absolutely not limited to all the presentations, it's just some of the more common ones. So obviously fevers can happen either because you do have an infection, and children, do not forget that children who have leukemia are, even before treatment, are very immunocompromised. I mean, the process that happens in leukemia, you have rash, yes, not a very specific. So I mean, they can have rashes, but I wouldn't diagnose a leukemia only based on rash. So what you have to think when you think about symptoms of hepatosplenomegaly, absolutely. So with symptoms of leukemia, you have to know the underlying process. So the underlying process is that you have malignant clonal cells, which is found in the bone marrow, and it just starts rapidly dividing. When it rapidly divides, it takes up a lot more space, and doing that, it affects other lineages in the bone marrow. So your erythroids, which are making your red cells, are being suppressed. Your platelets, your megakaryocytes are being suppressed. So that affects your pancytopenia. Fevers can come from because these cells are quite metabolically active, and they can secrete a lot of cytokines, and that causes your B symptoms. So it can be fevers, or it can be because your myeloid lineage is suppressed. So children are neutropenic, and that they have a proper infection. Bone and joint pain. Bone pain can occur because just the leukemia is booming inside the bone marrow. Oftentimes with Burkitt type leukemia, which has very high turnaround, they have quite intense bony pain, but not saying that others don't. But with Burkitt, it's very, very typical. Joint pain can occur, obviously, because of the bony pain, or because leukemic cells can infiltrate the joints as well. Fatigue and pallor can come from suppressing erythroid lineage, so your red cells are not produced enough, and children are just anemic. Oftentimes it can be a slow-growing leukemia, so they get used to very low hemoglobins. I had one. I was a teenager, but he presented with a hemoglobin of 32, and he said he was a bit tired. So bruising and petechia, again related to leukemic cells pushing out the megakaryocytic lineage, causing low platelets, thus bruising and petechiae. Cytopenias obviously is laboratory finding, but I thought it's so important that I had to put it in this list. Night sweats and weight loss can often be observed, and it's all part of the leukemic cells excreting cytokines, causing B symptoms. Then lymphadenopathy is quite common with ALL, particularly TLL. Hepatosplenomegaly, spleen is often enlarged. Mediastinal mass is already discussed, and it's quite common with T-cell malignancies. Respiratory symptoms can be due to either leukostasis or mediastinal mass or an infection, and neurological symptoms can also happen, and they can be either due to bleed or due to leukostasis. Those are kind of general direct leukemia effects that might cause these things. In terms of baseline investigations, well, we already mentioned most of them. Full blood count is your most important one. Reticulocyte count is good practice to send, not so much because it would be diagnostic of leukemia, but because children who are pancytopenic reticulocyte count, your working diagnosis, if you don't have a high count, it could be leukemia, it could be aplastic anemia, and reticulocyte count is very useful for us to further think about other working diagnosis, and we will ask you for reticulocyte count. LFTs, USNEs, calcium bone profile is your standard biochem. Mostly we're looking at bloods for tumor lysis, which we'll touch a little bit later on. Urate is also a marker of your tumor lysis. LDH we discussed about. CRP can be mildly raised in leukemias, but it is useful to distinguish infection from something else. Clotting screen, we already said never forget the clotting screen because in APML it can be quite deranged. Group and save, and that again to rule out any other things. I mean, bicytopenia and something like anemia and thrombocytopenia can happen in other syndromes such as Evans syndrome, and then that will be positive. You would not expect it to be positive in leukemia. Blood film, one of the most important things, as we mentioned. I've put peripheral blood flow cytometry in brackets. It all depends on the presentation we'd like to be and we would like you to discuss with us. Oftentimes, if you're suspecting this might be low count leukemia, we might ask you for a blood film and send an EDTA sample, and then we decide based on the film whether we need to flow it. Low count leukemias are quite tricky ones, especially if the local team oftentimes will not be sure what to think of. In younger children, lymphocytes which are reactive often look quite insidious if you apply your adult hematologist brain to it, but we're quite happy to review film. Just as a practice note, I often get asked what forms to send. There's just unfortunately one form, and if you Google GOSH external film review, you just write the details there and as much clinical details as you can, and it doesn't say anything about flow cytometry, but if you send us an EDTA sample with that, we can decide whether it needs to flow. That's just a little side note. We do flow when they come over here anyhow. G6PD screen we discussed, chest X-ray we discussed, and ultimately when they're transferred here, the most important things are your bone marrow aspirate plus or minus trophine, and then in the same procedure we do lumbar puncture and administer intrathecal chemotherapy. So, as somebody already mentioned quite well, bone marrow aspirate is important. It's your diagnostic sample. Most of the time we get an aspirate, so we draw a little bit of aspirate from the bone, but oftentimes these children can have quite fibrous marrow, so we don't manage to get anything, so you get trophine, which is essentially your core biopsy of the bone, and those are your diagnostic samples. Flow cytometry is most commonly used to distinguish which type of leukemia a child has. Now, this is just a bit extra. Obviously, you won't be doing this in a DGH setting, but I think it's good to know what type of bone marrow investigations we do for most malignancies, essentially. So when we take a bone marrow aspirate, we always take a sample to look at the morphology, and this is what we do ourselves, and we can diagnose most problems just by looking at it. Obviously, we do a lot more tests, and the additional tests are normally flow cytometry, which provides you some type of acute leukemia. So as you may remember, flow cytometry looks at your markers on the cells and establishes percentage of the population with a certain marker of the cells, and just by looking different profiles of markers on the cells, we can establish which leukemia it is. Then we do cytogenetic tests using karyotyping and FISH, and that helps us stratify the risk of the leukemia. And we also do molecular analysis, so DNA-based test, which help us both stratify the disease, the risk of the disease, but also to help us monitor disease with what we call MRD. We do flow and molecular MRD normally. Now, in terms of what types of leukemias, so we've already mentioned that there are two most common types of childhood leukemia, and it all depends on what sorry. Okay, so G6PD, we do, so I'll come back when we come to tumor lysis to G6PD. I've explained it already once. So when we talk about types of leukemia, you need to think, I don't know if you see the arrow when I point it, probably not, but it's important to know when you type in leukemia, what cells they stem from. So your most common leukemia is ALL, and it comes from lymphoid cells, and it comes normally from this side. You can see where the arrow is now, and that's your ALL. It can be different subtypes of ALL. It can be pro-B, pre-B, it can all the way down to mature type B cell leukemia, in which case we sometimes call it Burkitt type. So it can have different types, different subtypes, but they all stem from the lymphoid line. Another type of common leukemia obviously comes from the myeloid line, and it comes from this cell, which is called myeloblast. And then we can have different subtypes of acute myeloid leukemia or AML. So it's just important to know where they come from, both of them. ALL is much more common than AML, but they're equally quite important, and I'll explain why. I won't go too much into treatment of ALL or AML, primarily because I think, or at least what I've been asked to do, is to prepare you for knowing your leukemias at a ST4, ST5 level. So that will be your DGH setting. But it's important to know at least basic modalities that we use. And obviously, all leukemias are treated with chemotherapy. Children are normally, and we try to enroll them in trials whenever we can. And for ALL, there was a trial called Untitled 2011, which was a national trial, and most children were treated, were enrolled in that trial, or even if they don't consent, they are. That was one arm of it would be taken as your standard of care. That trial closed, and a new one is opening soon. But in the interim, we are using an interim guidance, which is called Untitled 2019, which takes one arm as your standard of care, and we treat them according to that. Duration for ALL, it's 2 to 3 years. Normally we say it's 2 years from something that's called interim maintenance for girls and 3 for boys. So boys get approximately a year longer treatment. The survival rates for ALL are quite good. You need to realize when you think of treatment in ALL, it's, I think, 70, 80 years ago, so in the 50s, 60s, ALL was not a good diagnosis, and most children died. But then with advent of new chemotherapy in the 70s, 60s, 70s, and then starting multicentric trials in children, these numbers just kept coming up. And now we live in the advent of immunotherapy, where we have new drugs, but also cellular therapy that's bringing a bit of a revolution to the worst kind of disease, which is either relapsed or refractory disease to chemotherapy. And I think a lot of new things are happening there. This is just as a side note. I don't think you need to know all of that. Just to have an idea of what different stages we have, I hope pretty much everyone knows the main stages of chemotherapy in most malignancies. So always you have blocks of chemotherapy which you call induction, and this is where you try to achieve complete remission, and complete remission is what you obviously want to try for whatever your treatment modalities are further. And in ALL, it's a little bit more convoluted with more phases where you slow down the treatment, then intensify it. So you have the different stages, but and this is just an example of one arm and the standard risk arm, where after induction you go into consolidation phase, then we have interim maintenance, and then you have another intensification, and then after that you go to final maintenance, which is quite long. Those are just kind of basic blocks of your chemotherapy, but for most malignancies it will be induction, consolidation, and some malignancies have maintenance, some don't, depending on the malignancy. I'm not talking just hematological, I'm just talking malignancies in general. So those are your three main stages. In terms of AML, AML is a bit more difficult disease to treat. Obviously, it is treated with chemotherapy, but depending on your risk, and remember those cytogenetics that we did on a molecular basis, so that's all important in establishing how risky your disease is. So some children with AML can get away just with chemotherapy. Some will need chemotherapy, and then on the basis of getting into complete remission, you can go to hematopoietic stem cell transplantation, which you hope will be curative. We do have a trial that's currently open, and it's called My Child, and I will show you the design of the trial, but obviously you don't need to know all of that. Just knowing that there is a trial is good. So survival with AML is a lot lower than ALL. It's around 65 to 70% overall survival, but it is second most common leukemia, and we are in a need of new treatment modalities. In terms of the trial and how we treat it, this graph shows the whole trial schema, so it's a lot more complicated, but you can see that there's normally 4 courses of chemo, and it can end up either at the bottom, where you can see that these children go to transplant, or they might end up and they might just be fine with 4 courses of very high dose chemotherapy. What I would like you to take from this teaching is just knowing the basic management of a new diagnosis in your setting, and I've divided that into 7 steps. So your number 1 should always be to support your ABCDE, so always support children as much as they can do baseline investigations. So we talked about that in the beginning. Talk to your PTC, do discuss with the family before sending them to your referral center. Start IV antibiotics, follow your neutropenic sepsis or febrile neutropenia protocols. Majority will have piperacillin and tazobactam incorporated. What I would like to know is your BNF would tell you that pip/taz is 90 milligrams per kilo TDS, but actually hematological patients, because of we want to achieve higher trough levels, we do QDS. So if your pharmacist ever question you, hematological patients get 90 milligrams per kilo QDS, and then you can add in amikacin and gentamicin, whatever your local protocol is. Starting IV fluids, I would definitely encourage you to. Different people will tell you different things, whether to start full maintenance or hyperhydration. Hyperhydration is normally established based on the square meters, and that's just how trial hyperhydration was prescribed. So normally we would start around 2 to 2.5 liters per square meter per day. And I don't know, personally, I like starting hyperhydration, but somebody already raised quite nicely that it might drop your hemoglobin, but if your hemoglobin was 17, it's not going to drop it down to a significant level. So it all depends. And in the child from the first case with white cell count of about 400, I would definitely start them on hyperhydration because it might help with your leukostasis. Allopurinol, starting allopurinol is good practice. It's 100 milligrams per square meter TDS, and obviously need to transfuse if necessary. And this is where we talked about G6PD. G6PD is important because when we treat for tumor lysis syndrome, we use respirocase, and respirocase very potently activates hemolysis in children who are G6PD deficient. If a child has been transfused, we cannot reliably say then if their levels of G6PD are normal, or we are just detecting G6PD in the transfused cells. So this is why G6PD is important. Now, I know that this part you've gone through with Danny Chang. I'm sure you've touched on it, but I think it's very important when you're stuck in a DGH on your own. So we'll quickly go through that, and I apologize if I'm repeating too many things. I reduced the number of hematological emergencies. I would say there's 6 hematological emergencies. I think I put just 4 here, which would relate to your leukemic patients that you might deal with. Febrile neutropenia is your absolute number one, which everyone will come across working as a general pediatrician. You will see children who will need treatment according to febrile neutropenia, and I'm sure you know it all too well. But I will emphasize that a single temperature above 38, even though if it's not in a hospital, does classify as temperature. It doesn't need to be recorded in a hospital. I think a few years back, more than a few, it's been a change with that. And then febrile neutropenia and neutropenic sepsis is defined by neutrophil count less than 0.5, but in most cases you will not have time to wait for the neutrophil count, and you shouldn't. So normally temperature above 38 and somebody who you know is immunosuppressed, so a patient who you know is on chemotherapy, or as soon as you, in this case, as soon as you find out that a child has a leukemia, you can treat them as immunosuppressed. And if they had a temperature above 38, you should start antibiotics. Obviously, do your baseline bloods, do your cultures, but you should be treating with IV antibiotics within the first hour, because unfortunately, children, well, majority of children with febrile neutropenia turn out to be fine, but those who don't can deteriorate quite rapidly, and unfortunately, it's not a nice thing to experience. So always think of your febrile neutropenia. Somebody already asked about leukostasis. So the terms leukostasis and hyperleukocytosis are quite interchangeable mostly, even though hyperleukocytosis refers only to the number, and that number is above white cell count, total white cell count above 100. So whenever you see white cell count above 100, think of looking for signs of leukostasis, and leukostasis occurs mostly, it's a little bit more common with AML than ALL, and some blasts, and the way it's explained is that myeloid blasts stick a bit more to each other, and they can form occlusions in the blood vessels. Now, where those occlusions form will give you your symptoms. Most common places where leukostasis symptoms can occur is your brain, and then you have neurological symptoms, or your lungs, and you will have respiratory symptoms. How we manage leukostasis, number one is hyperhydration. So if you have a patient with a white cell count above 100, I don't think anybody will object if you start them on hyperhydration. And we said already it's 2 to 2.5 liters per square meter per day. Other than that, your ultimate treatment will be giving cytoreductive chemotherapy. You won't be doing that in your in a DGH, but this is why you need to transfer them as soon as possible to your tertiary center. Very infrequently, we can do leukapheresis. That means putting them onto a machine and taking away the excess of white cells, or sometimes exchange transfusions, which honestly I've never seen being done in hyperleukocytosis. So that's something to look out for neurological symptoms or respiratory symptoms with high white cell count. It's also good to start them on allopurinol, and we'll come to that a little bit later. I already mentioned the importance of doing a chest X-ray. Sometimes children might not be symptomatic of anything, but if they do have mediastinal mass or the symptoms are very fine and not particularly convincing, they still have a higher risk of obstructing their airway. Oftentimes you will have a history of either cough or wheezing or autopnea, and it's important because these children are very high risk of anesthesia and intubation. And equally, the treatment would be steroids, infrequently radiotherapy if they're more solid tumors. But again, if you give steroids, then you're destroying tissue you might want to get to establish what malignancy it is. So it's a very fine line how much steroids to give, and don't give it on your own. Always contact your tertiary center, discuss with us, because it is quite a difficult situation to be in. Tumor lysis. I'm sure everyone heard of tumor lysis, and I'm sure Danny explained tumor lysis to all of you. So essentially what happens is the tumorous cells, when you start chemotherapy, or oftentimes just on their own, and some blasts are just very delicate cells and they can lyse on their own. Essentially they burst and they spill out whatever was inside the cell. Now this can cause several symptoms. Obviously inside the cell your potassium is predominant, so it might cause hyperkalemia. Equally, inside the cells, the release of DNA and byproducts of DNA will increase your purines, and which then can produce uric acid, and uric acid can cause urate nephropathy. So this is why you can give your allopurinol, which is a very inexpensive drug and can be found anywhere. Or once they properly start tumor lysing, we use resburicase, and you can see lower down, resburicase is a very efficient drug of turning uric acid into allantoin. Your other symptoms obviously is that you have increased phosphate. When your phosphate binds to calcium, you have hypercalcemia, so you will have symptoms of hypercalcemia, and equally calcium phosphate complexes can cause nephropathy as well. I'm not going to go too much into detail how you diagnose tumor lysis. I'm sure Danny has done that with you, I think, on Thursday. But there is a specific laboratory and clinical criteria, which is called Cairo-Bishop criteria, and there is a national guidelines. If you just look up PSH tumor lysis guideline, it's a good guideline to look at. What's important with TLS management with tumor lysis, resburicase obviously just helps your uric acid here. It does not help, it does not do anything with hyperphosphatemia, hyperkalemia. So all of that you still need to manage medically, however you would manage in real life. So that's just something not to forget, that once you give resburicase, you do not treat anything else apart from what the pathway that resburicase affects. One more important thing, when you start hydration or hyperhydration, don't ever start children with a suspected malignancy on fluids containing potassium, because if they do start tumoralizing, it might just push them over the edge and cause that much more hyperkalemia and cause them problems. Last one that I want to mention that I'm not sure whether Danny mentioned, and it's not solely hematological, is coagulopathy or bleeding. And I explained that there is a subtype of AML called APML, or acute promyelocytic leukemia, which actually has a fairly decent prognosis, and it's more easily treatable. But in its presentation, the blasts and promyelocytes tend to cause quite a severe DIC, and patients can have spontaneous bleeding, which is not infrequently sometimes intracranial bleeding. So this is why it's important to always check coagulation screen when you suspect a leukemic patient. This is also one of the very few instances where, as a hematologist, we throw literally everything we have at them, because even if they're not bleeding, we try to correct coagulopathy, because we know that mostly they do bleed because of their coagulopathy. So we give them fibrinogen concentrate or crack precipitate, whichever we decide. We'll give them platelets and FFPs, everything thrown at them, and obviously we give ATRA, which is all transferrin tretinoic acid, which corrects the defect in the pathway. I'm not going to go too much into that. So as for the end, and we're coming slowly towards the end, I will give you case 2, which is a 5-year-old girl who presented to her GP because she started spiking temperatures 2 days ago when maximum temperature was 38.4. Parents reported 2-week history of tiredness, and the girl complained of pain in her right knee. GP did not do any bloods. On examination, she was alert but looked quite tired and pale. There's good bilateral air entry. Splenomegaly measured 16 centimeters. She did not require any oxygen, and she did not have any gross neurology. So what are the next laboratory investigations that you will do? Absolutely, always full blood count. Clotting, well done. Chest X-ray, perfect. Yep, G6PD, thank you. Yep, all fine. I can see CRP in cultures. Yep. So you've said everything right. Your first line of investigations, you've completely got everything right. So your full blood count came back as hemoglobin 45. White cell count is 2.1. Neutrophils are 0.6. Platelets are 20. Reticulocytes and absolute count is 18. Blood film is still pending. Your userness are fine. LFTs are fine, and coagulation is fine. And then other investigations you also mentioned, it's your urate, calcium blood profile, LDH, G6PD, group and save, clotting you've requested already before, and then you chase the blood film, and your local hematology registrar said that there might be some blasts. They are not really sure. What do you do next?
Bone marrow?
It will end up with a bone marrow, but you wouldn't do it there. So you would refer to your tertiary center. What else in this patient? So mind you, look at her count, and also she's been paraxial. So what would we do? Start antibiotics. Well done. Which antibiotics? Tazocin. Okay. Do you remember Tazocin, QDS, and hematological patients, and Gent or some Trastat amikacin, depending on your local resistance? Yeah. So well done. Now, this child is mildly tachycardic. What would you do? For this one, I would start IV fluids cautiously. ECG, yes, absolutely, but blood transfusion, well done. So I would definitely transfuse them. Don't transfuse them too much because you don't want a fluid overload either. I normally would go with increments of 20, so I would probably target this child could get the increment up to 70, and if we increment her up to 70 or thereabout, that would make her probably stable to be transferred. Platelets are 20, and our thresholds for paraxial patients is 20, so I probably wouldn't do anything and try to get the patient over. You're quite right, when we get the patient over, we would do a bone marrow, and that would ultimately tell us what it is. We might do peripheral flow, but that's beyond the topic of this training session. Right, so this is your management, which we touched upon before. So you supported her ABCDE, you've done her baseline investigations, you referred her to your principal treatment center. You started antibiotics, you can give her fluids. With low count, as I mentioned, a lot of people will tell you maybe to just start maintenance, especially if now the HB is in 40s region. I probably wouldn't start hyperhydration, but this is why you have us, so just call us whenever. If you start just maintenance, you can't go wrong, and we can always up the hydration. But if it's something obvious of 400 or above 100, I think your hyperhydration is okay, provided your hemoglobin is reasonable. So always touch base with us, and we'll happily guide you. Starting allopurinol, good practice, and obviously transfuse patient what is necessary. We are going to continue doing that, but if the child is tachycardic and hemoglobin of 40, I'm not sure how safe for transfer they are. So I think it's reasonable to transfuse. Just always think of G6PD, and just to reiterate once again, it's because viral serology like varicella, that's a good question. I wouldn't ask you to do that. So why we do serology and all the testing is before chemotherapy, and we can do that even if you transfuse, it's not going to be effective. So that's from your serum. So no, the answer is you don't have to do that before the transfer. And currently, the only thing that's affected by transfusion is G6PD screen, at least that I can think of. Before we did TPMT, but TPMT can now do genotyping from white cells. So G6PD is most important before a transfusion because it's very hard to find pre-transfusion samples and test it. And as I mentioned, rasburicase can be an important drug in the induction phase if they start tumoralizing, and you don't want them to hemolyze as well as tumoralize. So this is why G6PD screen is important, and I think if you can do whenever you have in local, and all locals do G6PD screens, if you can do it in local, it's always good to have a backup. We might repeat it here, but it's a fairly inexpensive test that can be done in local. Right. Any other questions? Boys, just according to trials, they're higher risk. That it's the way that protocols have been designed. Any other questions? Sorry, the question was explain GCPD, especially intermediate levels. Okay, so it should not be reported as intermediate. So most G6PD testing should be either done as a screen or levels, and what it should be reported as, it should be as levels, and it depends on how you interpret it. Sometimes it can be, well, patients can be heterozygous and have low end of normal, but then you are pretty much guided by your clinical picture. In G6PD deficiency, I had a female patient, so there's a 4-year-old who would have lower end of normal G6PD, but normal levels, hemolyzed every time she ate fava beans. Yes, I know, very particular history, and turned out to be on genotyping heterozygous. So intermediate levels can be heterozygous, but not always. So it's also important when you take the levels. So if it's straight after hemolysis, you will have a lot of reticulocytes, which will have higher level of G6PD inside. So maybe 3 months after hemolytic episode would be the best time to repeat G6PD levels. Obviously, do them when they have the episode, but if they're normal, it's falsely reassuring. So you'll have to repeat it in 3 months' time. Does that answer your question? Thank you. Hopefully this was beneficial. I'm sorry, interaction is not the best, but I hope you did manage to learn something.